Do I have? All right, let's have everyone sit down. I'm going to wait for Bob to give me the audio-visual cue, or the audio cue. Well, welcome everybody to Neurology Neurosurgery Grand Rounds, and it's a distinct pleasure to have as our visiting professor today Dr. Robert C. Griggs, who we all affectionately call Birch Griggs by his nickname. So Birch is from Delaware originally, but what I did not realize until yesterday is that his parents were born in Missouri and Kansas, so he actually does have Missouri and Kansas roots. He began training in medicine at Case Western in Cleveland, and then he was a neuromuscular NIH fellow with King Engel at the NIH in the 60s. And I don't know what they called the fellowships back then, but he was there at really the beginning of the where the neuromuscular specialty in the United States was developed under King Engel. And he was a fellow there with Jerry Mendell, which is where they met, and that's how I ultimately met Dr. Griggs, is through Dr. Mendell years later. So he was trained in neuromuscular disease before we even thought about the specialty of neuromuscular disease at the very beginning. He then finished his training in medicine, did more training in neurology and pediatrics, and he spent his entire academic career at the University of Rochester Medical Center, where he has served at various times as a neurologist, an internist, a pediatrician, a rheumatologist, and he currently attends on the stroke service at Rochester. Dr. Griggs was chair of the Department of Neurology for over 20 years at Rochester, and as you know, he is one of the preeminent neurologists in the country, in fact, internationally. He has been the president of our American Academy of Neurology. He had a wonderful run as the journal editor for our premier journal, Neurology. And in neuromuscular disease, Dr. Griggs has really led research efforts over his career that have set the standard for neuromuscular research in the world. And we have been fortunate enough here in Kansas to be part of the neuromuscular research juggernaut that Dr. Griggs has put in place, both through the Muscle Study Group and through the Consortium for the Investigation of Neurologic Channelopathies. And so it's been a great, great pleasure to be a colleague of Dr. Griggs for over 20 years, and actually to have him as one of my mentors. So we are so pleased to have Dr. Griggs come here today to our conference to give us an update on Duchenne dystrophy research. Dr. Griggs. Thank you.
Well, thank you, Dr. Barron. Today's introduction was even better than yesterday. I'm sorry I can't stay for another day. But thank you for all those kind comments. And it really is a privilege to be here at this celebration of Dr. Barron being made a distinguished professor. If you look down the list, it is impressive. I saw the list of distinguished professors. It was on the little card. Most of them are somewhat superannuated. I didn't want to say that yesterday, but you can tell that this is unprecedented to have somebody as young as Rick Barron become a distinguished professor at this school. And it reflects the fact that his leadership here has simply been transformative of the school, that the things that he has brought to fruition in an incredibly short period of time have really moved KU from someplace in the middle to beginning to knock on the top 10 or 20 places in the country. And everyone who's here and everyone who comes here is benefiting from his just extraordinary vision and leadership. The number of things he's touched, it's just incredible how he accomplished. He attained a grant for the CRC when they were no longer giving them out. He got the very last one, and then he parlayed that into a CTSU. It's just incredible. He's got this translational science unit. There were the competition for that. You just can't believe. It's not like regular NIH grants. The competition was just incredible. And so that, and I was privileged to spend time with the people there. It is an outstanding team of people. There isn't anything at other centers that matches it. It's just going to really continue to lead Kansas to even greater heights. So you're lucky to be here. You're lucky to have him, look after him, help him, and I look for great things in the future from KU. Now I'd like to talk today about not so much about this disease, but about some of the lessons it's teaching us about clinical medicine, clinical trials. These are the same conflicts and biases I showed yesterday. No new money since yesterday. Still money from pharma, but I would just want to make one point about pharma, is that KU is doing what I consider to be the smart thing. You must work with pharma. I was pleased to meet a PharmD yesterday, Scott Weir, who's a key figure nationally in NCATS, which is sort of everything you and I are interested in terms of research, is sort of now sitting under the National Center for Accelerating Translational Science, run by a neurologist, Chris Austin, and Scott Weir, although he's a PharmD, actually is very close to Chris, and this is important for you, important for all of translational research, because it's somewhat surprising to me that PharmDs have not been welcomed by neurologists, and so it's only through the leadership of the head of our CTSA, Carl Kieberts, who just took over a few weeks ago. He's a neurologist, and he sort of introduced me to the importance of PharmDs to neurologists. And so now we've accepted our second fellow into our neurological training program, who's a PharmD. PharmDs help you do pharmacokinetics, pharmacodynamics, pharmacogenomics, and these are things that I can assure you, if you sort of don't know what that means to you in your research or your practice or your clinic, you just have to learn. And so you really want to welcome the PharmD into our research enterprise and begin to learn what they learn. You have no clue the things that they know a lot about, modeling, and the FDA is interested in hearing from PharmDs, not from neurologists. PharmDs are the people that know how to get things done. So it's just to applaud Kansas for recognizing, and I wanted to make the point that without pharmaceutical companies, there will be no new treatments. We can do the trials, we can discover the treatments, but it takes a drug company to bring it to market and make it available. And so some schools, including my own, have not embraced the pharmaceutical industry the way they should. You must separate the detail men side and the marketing side of pharma from the research side of pharma. They are not connected in any way except by being under the same CEO at the top with different missions. So do not conflate the marketing problems that we get into with the marketing people trying to get you to use their drug for every possible indication and prescribe it by, it just goes on and on what they're trying to get you to do. But they're in it for they're trying to make money. That's a business. But the research people are just like you and me. There's nothing about them intrinsically. Now, occasionally they stay stray, and we know that, but who doesn't in the academic center have occasional flaws? So that's my point about biases and stuff. Okay, I'm going to talk very little about pathogenesis. I think I understand it, but I'm not an expert in it. I'm going to talk about the first treatment. I'm going to talk about the prospects for cure very briefly, but there's some important lessons in a recent big study that came out just a few weeks ago in terms of the results. I'm going to say a little bit about Equipoise. I think everybody's familiar with this term now. say a little bit about standards of care, and then I want to introduce, I suspect relatively few of you have heard a lecture on Fidelity. And so today is a lecture on Fidelity. It has nothing to do with your marital bliss, but it has everything to do with how we practice medicine. Now, Duchenne dystrophy, looking at the incidence, it's lower than it used to be. If you look in any text, it says twice this frequent. It's not. It's X-linked recessive, but a third of cases are new mutations because of this is the largest gene in the human genome, the Duchenne gene for dystrophin. And of course, 2/3 of the cases would be preventable by newborn screening, and actually the other third could be preventable by looking at fetal cells in the cord blood. I think we will be there within probably 10 years where that option would be made available to prevent all Duchenne dystrophy. They have the onset of weakness probably at birth, because we think that no patient with Duchenne dystrophy who has the mutation is ever able to lift their head against gravity. It's something they can't do right from the get-go. As soon as you're able to test them, you can show that they can't. That requires doing the test in the right way. Every time I hear somebody talk about the neck flexors, I just wonder if they know how to test them. Most of you don't. The way you have to do is you have to put the patient shoulders at the edge of the table and drop the head off the edge of the table, hanging down, and then ask them to lift it up. And many times with the resident will say, well, the neck flexors are 4. And I look at the patient, they have myotonic dystrophy, and I say, this resident does not know how to check the neck flexors, because in myotonic dystrophy, usually the neck flexors are not able to oppose gravity. But in Duchenne, the point is that they never oppose gravity. And so in a minute, I'm going to show you a video that shows a little boy lifting his head against gravity, and that was actually the first sign that our treatment for Duchenne dystrophy was miraculously, rapidly improving the strength of boys with Duchenne dystrophy. They almost invariably present by age 5. They cannot run, hop, or jump, even when they're little, even before that. And this point I've already made about the neck flexors. They gain function between age 4 and 6. This is why, and if you go back 50 years, there are literally dozens of treatments that were suspected to improve Duchenne dystrophy. They're presenting around age 5. You start something, and a quarter of them get better if it's a placebo. So they get better between age 4 and 6. They gain function. This is true of any any childhood disease. You've got growth and development occurring more rapidly than the disease is progressive. They begin to fall by age 5 or 6 untreated. They're confined to a wheelchair by age 10. And then they begin having respiratory difficulties 13, 14, 15, 16, and die by age 18 unless they're supported or treated. They have cardiac, and pleased to have a pediatric cardiologist here. Big deal. They have, and some of the mutations in the dystrophin gene actually present with the cardiomyopathy. They get severe GI problems, and about a third of them are below normal in terms of intelligence. There's dystrophin in all these tissues, and that's why this multisystemic involvement occurs. Now watch this video. This is Jared. I'm going to show you. He's on steroids. The test is not done correctly here. Now it is done correctly. So you see that? And he can lift his head up against gravity. Never without steroids, and he's able, not very impressive jump, but he's able to jump better than he could. So he can get up from the floor. Now he doesn't use the Gowers. You can see he's still weak, but he's on steroids, not using the classic. And there he's running pretty well. They cannot do that untreated. So this is the effect of corticosteroids that we're going to talk about today. Because they're missing this protein. They in general are out of frame, and so they have virtually no dystrophin. If you do a Western blot on their muscle, they do have mutations that occur in the dystrophin gene, mutations occurring in each of you as you're sitting here, and so mutations occur, and some fibers then become dystrophin positive because of what they call revertant characterization, that there's a back mutation that puts the gene back in frame. It probably doesn't fully correct the defect, but it puts it into frame, and that's actually one of the bases of a treatment that's being developed. What does dystrophin do? The old people in the audience were learned about muscle when it was just actin and myosin, and there were all these sliding filaments that resulted in the contraction. Never in my early studies, I started doing research and published my first paper on muscle when I was in college. Work when I was 18. That's when I started getting interested in muscle. I was working in insect muscle. At that time, it just actin and myosin, Nobel Prize for all of that work, St. Georgi. Never occurred to me, how does the sliding filament contracting make the patient move? It has to be linked into the sarcolemma, and that's what dystrophin is part of it. And there are literally dozens of proteins that help link the contractile apparatus and tie it together and link it in the membrane. And there is a mutation in virtually every one of the proteins, and that's what causes many of the other diseases. So we now know that the muscular dystrophies probably number well over 50. And so there used to be big 4, now they're 50. Each of these proteins have mutations. And so some of the things we're learning, all of the things we're learning with dystrophin probably have some relevance to these other contractile linkers in the muscle. So the pathogenesis then is because of missing dystrophin, the sarcolemma ruptures, and there are beautiful pictures from years ago showing the little tears in the membrane. Calcium leaks in, triggering a cascade of events, including inflammation. You then get muscle cell from the molecular assassination via the calcium, and then you get cell repair, rapid repair, that in the mouse model, actually the repair works and the fibers then seem to be resistant to subsequent injury. But in humans, eventually this repair probably exhausts something analogous to the Hayflick phenomenon. Everybody should know the Hayflick phenomenon. This is that if you grow cells in culture, they eventually senesce. They're not immortal unless you infect them with a virus, then you can immortalize cells. But in most cells have this defined lifespan, and that's probably why the cells stop regenerating. Hayflick was the father of actually a neuroscientist that's still around. So that Hayflick phenomenon is probably the reason for the exhaustion, and then fibrosis and fatty replacement. Turning now to the treatment. Amazing. Dan Drachman, still working at Hopkins, age 82 or 83. One of 2 twins, the Drachmans. Amazing person. He first suggested in a paper in Lancet that prednisone worked in Duchenne dystrophy. Absolutely no one believed him. Everybody thought this was terrible. So when our group, the CIDD group, the Clinical Investigation of Duchenne Dystrophy, which is in fact the first big study group in all of neurology, started doing studies, we didn't even look at prednisone. And finally, after we did like 5 or 6 negative trials with vitamin E, penicillamine, and other sorts of poisons, we turned our attention to prednisone because some people were still giving prednisone, and we thought that was awful. And when we gave the prednisone, we didn't even do a double-blind study. We did a natural history controlled study. Initially, the clinical evaluators said, hey, the patients are getting better. They're lifting their head against gravity, which they'd never done before. And we said, that's absurd. We know it's not true. So then we did a big double-blind study that we reported in the New England Journal, showing that they were absolutely right. And this, you remember we talked yesterday, those of you who heard me, we talked about how when you're doing a clinical trial, you're trying to often slow the progression of Alzheimer's. If we could slow the progression of Alzheimer's disease by 25%, we would reduce the burden of Alzheimer's disease possibly by 50%, because you could start we now know how to make the diagnosis probably 15, 20 years before it started, if you could slow it. So slowing is a reasonable goal, Arrest is a wonderful goal, but in Duchenne dystrophy, this treatment improves them. So we did our first controlled trial in '89 with a paper in the New England Journal, and there have been 5 placebo-controlled trials. Mike Brook led these studies. Jerry Mendel was involved. Jerry Finichel and I were the team of 4. And we did multiple studies. We actually have done 5 randomized controlled trials of prednisone and Duchenne dystrophy to show this benefit. We showed that 1.5 milligram per kilogram was too much. We showed that alternate day was not as good. It's a really important lesson. It's one of the few studies that was really rigorous comparing alternate day steroids with daily steroids. And we used alternate day steroids. There are very few other studies where they've done this really, really careful head-to-head comparison. I'm not going to show you that data, but it was really impressive that they didn't do as well on the alternate day. We used lower doses to see if we could get away with less, and you couldn't. So 0.75 milligram per kilogram is the optimum dose, and they get improvement easily measured in a small study of 6 patients, shows significant improvement by 10 days. We did that study. We have 18 months of placebo-controlled data and then did open follow-up for up to 3 years and showed prolongation of virtually everything we used over that period. Over the ensuing decades, other regimens have come up so that by a few years ago, when we looked at what was being done, it was clear that there was absolutely no agreement about what regimen you should use, despite the fact that all our controlled studies were done with 0.75 milligram per kilogram. Now this shows, and I want to just call your attention to, this is the study showing 1.5 milligram per kilogram versus 0.75, and you see that not really much different. Maybe a little faster, but eventually they plateau at about the same level. This shows the natural history line. This shows that there is a little placebo effect. And this shows then the course. And at 3 months, they improve up till 3 months, then plateau. How long is this plateau? We know that it's up to 18 months, but suspect at 18 months they then start to progress at a somewhat similar basis. So why are we doing a big study now? And KU is one of the centers in our new study looking at Duchenne dystrophy. And children's, yes. So both sides of the imaginary line between the states. But your CEO has done a really, really good job of bridging that imaginary gap. Dr. Garage. So, is there equipoise over treatment? Equipoise being genuine community-based uncertainty about a treatment. Some people say it's necessary for clinical trials, although there's a lot of question more recently about whether that's true. Don't have time to go into that. But if there's equipoise, really good people disagree about what regimens. And so we did some surveys. The majority of centers don't use this dose of prednisone, and in some whole countries, when we started looking at this, France did not use steroids. Not at all. And probably the majority of countries in the world do not still use steroids. Despite the fact that there's a Cochrane review and an AAN practice parameter that concluded and then concluded again and looking, updating their things, that their prednisone is of benefit for up to 18 months. We don't have data past that. So this is why we're doing this study. It's a European and community and MSG study. It's in 5 countries, 40 centers, including Kansas City. We're studying 300 patients. We're going to use 3 different regimens. The gold standard, if you will, was used versus one that's available in Europe. And deflazacort has been used in Europe. It's available in Europe. It's not approved for Duchenne, but it's used there. And people in this country can get it as you can get any drug that's available in another country. You can import it for single use in a patient. It's legal. Versus what's been known as the Dubowitz regimen, 10 days on, 10 days off. Now we have an extraordinary situation in that in this country, most people, physicians, think that deflazacort is the best, and so they're getting it for their patients from Japan, from Mexico. A little shaky, the production in Mexico. I'm not sure they're really getting deflazacort, or from some other country, and try to get it for their patients. Patients are desperate to get it in this country. Whereas in Europe, actually, where deflazacort is available, this is the regimen they think that's the best, because although it may not be as effective, it does have fewer side effects. There's pretty good evidence for that. So the real question is, if you're going to give this treatment for the rest of the life of a patient starting at age 5, what's the risk-benefit of one regimen versus the other? So our study is comparing these and looking at standardizing cardiac, respiratory, GI, diet, all the other things, eyes, everything we're doing, everything regimen is supposed to be standardized, and we are standardizing the corticosteroid side effect management. This has not been done. Even the CIDD study didn't do it as carefully as we're doing it in this study. This is going to permit us to have a standard regimen for all aspects of Duchenne dystrophy. It's based on a consensus paper that was published in Lancet 3 years ago by Katie Bushby, who is my co-PI on this big study. We then will have it's not necessarily the best way, but it is an agreed way. And once you've been able to standardize care, you can then have somebody come along and say, we'd like to try a different something to compare it to the way it was done in a standard fashion. So we're following the patients for a minimum of 3 years and 5 years, and the NIH actually, the study section was anxious that we continue doing it, and we're planning on extending this study for 10 years to look and see which regimen is best. And the primary outcome is a composite. For those of you interested in clinical trials, let me point out the power that you get from composite outcome measures. If they are not totally interdependent on each other, they add power, so you can do studies with fewer patients by having a composite outcome. I learned this from Gil Wolf's John Newsom Davis myasthenia trial, where they have a composite outcome, their thymectomy trial. So we're looking at FVC, which is the most accurate and reproducible measurement in Duchenne dystrophy after the boys are able to do the test reliably. It's a little trickier when they're very young. Time to get up the floor from the floor, which is a surrogate for the ability to walk, and then something that I think is really important, and that is a treatment satisfaction scale. That's something else to get those of you who are involved in clinical trials to recognize the importance of this patient satisfaction scale. It's used in oncology especially, and it is a scale that the drug companies and marketers and FDA are particularly interested in, because if you don't like the treatment, even if it shrinks the tumor because it has such bad side effects, the satisfactoriness of the treatment is not good. This means then that the patients that won't buy it, the doctors won't prescribe it, and the fact that it shrinks the tumor or improves Duchenne dystrophy is, so what if it's not a medicine people are going to take? So that's why this scale is so important. We're pretty sure that does add power, because it's not like just measuring how fast they get up from the floor. Recruitment started in January. It's funded by the NINDS. The MDA is giving us support for travel costs. Parent Project is giving us support for ancillary studies we're doing with it. This is the paper that came out earlier this year that just documents the corticosteroids and major variations in practice. And what we did is we looked at the data that's not yet been published from the Adalurin trial. You'll see that Leon Atkinson, terrifically talented clinical investigator, and these people are all these people are from PTC. Valerie Swick, the MDA, did a survey, and so she's part of it. And so this is a trial that was done, these are based on surveys done in Europe by the MDA and the actual data from the Adalurin trial in terms of steroid doses, and it just showed that there are 29 different regimens for steroids. No standard treatment, no standards of side effect prevention and long-term treatment. And although PTC claimed that the heterogeneity of regimens didn't matter for their trial, I am absolutely certain it does, because the time, if you saw that time course of the steroid effect, they said, well, everybody was on the same dose for at least 3 months. Well, if you look at that, that doesn't, they're changing. The course of the disease is changing. And so they allowed in a clinical trial ad lib steroids. That is still the case in most of the trials that are being done. So you can see that unless we have standardized steroids, which are being used in conjunction with any new treatment, unless we have the right regimen, it's going to be an incredible confounder. Systematically confound the studies that of any new treatment. In this study, of course, one of the other big things they're looking at bone, particularly is that an Italian group are looking at bone. We're looking at proteomics to see what changes, and we're going to be looking at genomics. As you know, those of you who follow the literature, there was a paper in the Annals recently showing that there's a marker that determines the severity, an additional genetic marker determines a more severe phenotype of Duchenne dystrophy. And although it's a very stereotyped disease, there are differences between patients for several years in terms of when they lose ambulation. And so there are other genetic variants that are important in the disease, and we're going to be looking at those as well. So this just makes the point there are, which steroid you use is going to be important when you develop a new treatment. There are different benefits from different agents. There's varying time courses of benefit. They improve in 10 days. They plateau at 12 months probably and begin to decline by 18 months. And so it's going to affect the study power. The adverse effects will be different depending on the regimen. And who knows but what there might be different drug interactions between a new agent and one or other steroid. So why steroids right now when everybody's all excited about fixing the genetic defect? Well, none of the treatments have any strategy that's proposing to cure the disease. So they're mostly going to turn a Duchenne patient into a Becker's at best. The Becker's are, those of you who know muscular dystrophy know that it's a much milder dystrophinopathy, so that none of the new treatments are likely to be curative. Most of the new treatments are targeted towards single or specific exon treatments. And this is the really important one. People underestimate the benefit of corticosteroids. They walk 30% longer. They stay off the ventilator, and I have patients, there are lots of patients with Duchenne dystrophy now going to college, graduate school, getting jobs, getting married. It has changed the natural history, and the treatment is a much more quantitatively, much more beneficial than pacemakers, defibrillators, and virtually all palliative cancer chemotherapy, and yet many patients are still not getting this treatment. This is just an extraordinary crime and a shame. And it was actually the parents of patients who lost kids with Duchenne dystrophy that pushed us to do this study in the first place, pushed Katie Bushby to come to us and say, we want the muscle study group to do this study. This trial will, of course, establish centers in 40, standards of care in 40 centers in 5 countries. So what about the cure for Duchenne dystrophy? And that's been one of our problems with recruitment. Everybody's waiting for the cure, and they say, well, steroids are not that big a deal. Steroids are a big deal. I just told you how much of a benefit it is. But lots of things have failed. I'm on an advisory board for the Italians. There's a mesangioblast study that's going on, being in patients. And then, of course, antisense-induced exon skipping under study. Adalurin, PTC is still trying to see if this treatment, I'd share their DSMB. Utrophin upregulation, Kay Davis is working on that. That's a dystrophin-like protein that is upregulated in Duchenne dystrophy, and if you could restore or increase the abundance of utrophin, it might have a protective or corrective effect. Other proteins are being looked at. Various strategies manipulating IGF-1 are being looked at. I want to just make a couple brief comments about the recent Prosensa versus Sarepta. All the neuromuscular people are keenly aware of this and very excited about the possibility that in exon 51 mutations, where there's a strategy to bypass the defect, the results of the trials have just been reported within the past month. The Sarepta trial was reported at the Muscle Study Group in Oxford. The Prosensa trial appeared just a few days later. It's only been published that I've seen in the Wall Street Journal. That's where it first was reported. Interesting to compare these. There's such important lessons for us about the treatment of Duchenne dystrophy and the outcome measures. The Prosensa trial that was reported in the Wall Street Journal, 186 boys, and this is how it was done, versus Jerry Mendel's 8 boys. 1 investigator, 1 center, 8 boys, 4 active versus 4 placebo. Prosensa trial, negative. No improvement in the 6-minute walk test. Sarepta trial, Jerry Mendel's, positive. Improvement in the 6-minute walk test. And the Sarepta trial, dramatic increase in the dystrophin-positive fibers. Really impressive. 25 to 50% of fibers now have dystrophin by immunohistochemistry. So obvious on the slides. Why the difference? Well, for one thing, the 6-minute walk test. Probably everybody in the audience ought to know this test if you don't, because it is really being used as almost the gold standard for treatment trials in both muscle disease and in pulmonary disease. It was first used in pulmonary disease, where you're improving oxygenation. Not surprising that it worked there. But does it make sense for it to be used in muscular dystrophy? And most of us who were consulted by various companies when they started to do this said, bad test. It's going to test the motivation of the patients and their energy, their fatigue, not their strength. Because if I tell you, I used this illustration with some people yesterday, if I say, let's have you see how far you can walk in 6 minutes, you all set out, by the end of 3 or 4 minutes, you're sort of sick of this test. I mean, if you're a little boy at age 5, you were sick of it a lot sooner than if you're an adult. But if I said to you, I will give you $1 for every additional step you do, or let's say, no, you're a neurologist, you need $10. Okay, I'll give you $10 to motivate you. You're gonna go a lot further, I predict, on your second test. Now you're getting money for it. Even though you might be a little tired out for the first one, I will bet you will go faster. And in kids, there's all sorts of reasons why you're going to. So you can just see why this test. Most of us that have been testing kids said this is really a dumb test. Interesting. The person who's most enthusiastic about it is Craig McDonald, who's a physiatrist. Physiatrists. Their specialty is all about motivation, isn't it? That's, rehabilitation is motivation. That's get people moving. And so it's really interesting. So, and then this is really important. This just shows you how good Jerry Mendel is at doing things. When you ask Prosensa, well, what about the Duchenne? What about the dystrophin? Well, we're having a little trouble with that. I tell you, when Jerry Mendel does things, he does them right, and that's why both Rick and I are proud to have been taught by him. Although he's the same vintage as I am, he's taught me so much. He's a very careful investigator, and so I worry that Prosensa, they're not the same level caliber. So I think the jury is still out on this, because this tiny little trial did show this. I think that's important. So that's my sermon on that. Now, I've mentioned a tool, Gowanda. This is really embarrassing to us collectively. Any neurosurgeons stay here from the last hour? Okay. Yeah, no, I'm not offended. I just didn't want to offend them. This book is a tool. Gowanda is a general surgeon, and he's teaching us how wrong we've been. If you haven't read this book, you really should. He's such a clever guy. But he's not only a general. He's at the Brigham. He's a terrific writer, New Yorker, and then he's written 3 books. Better is the best. He's written Complications, and he's written the Checklist Manifesto, and he has published a paper in the New England Journal about the use of checklists. So neurologists, I tell you, we have, I mentioned this yesterday, there's the Barron approach, there's the Amato approach, there's the Griggs approach, and we will argue in favor of our approach. This is wrong. Every patient should be treated the same, so you, at least initially for starters, then you can learn something about the outliers and other things. And I made the point about N of 1 trials because each patient probably does have some difference, but we at least need to have a common starting point in terms of the system we use to take care of patients. And that's so I just want to point out that he wrote about cystic fibrosis, and I told the story yesterday, but we have to do the same thing in Duchenne dystrophy, and we're working on it. The report, I think that this is a hypothesis, but I think the reporting of outcomes could be a shortcut to standardizing the care in Duchenne muscular dystrophy. I despair of getting everybody to do the same things the same way. Neurologists just aren't like that. However, this was a paper that my resident, Michelle Scully, working with Valerie Swick, this is really an important paper. Bruce Marshall is the head physician at the Cystic Fibrosis Foundation. Turns out he was my intern, and that's maybe one of the reasons he was so agreeable to working. The cystic fibrosis experience is reported in this paper. It's never been reported before except in the New Yorker. They haven't written a paper about their success. This documents it and talks about it. So this is I like this paper. And so it talks about, just proposes doing the same thing in Duchenne dystrophy. And it includes one of Gary Gronsess's co-workers at the Academy. Tom Getch's a really smart staff person there. So that we're trying to bring everybody into alignment to do this. Public reporting of data, because that's what the Cystic Fibrosis organization started doing. If you want to be a CF clinic, you have to make your data, collect it, and make it available on the web. So I think I've convinced the MDA to do this. And they're starting small, but they're planning on doing this. In this process, it's obvious that there are going to be a number of clinics that close because they're not prepared to do this. And what would the criteria be? I would say the number of genetically confirmed cases. This would get rid of the clinics that aren't interested in doing genetics. The age at which they're diagnosed. If you're not on top of things, you're not taking good care of the patients, you're not getting the patients in the community to come to you. The age at which they lose ambulation, the age requiring ventilatory support, the survival, and that's it. You could look at other things, but just those things would make an incredible difference. If you reported that, you'd see that there are clinics where your patients are dying on the average at age 18 versus clinics where they're still surviving into their third, fourth, and fifth decade. It means they're given good ventilatory care. They're doing everything right. And as soon as that data become available, it will be, people change. They'll say, yes, steroids are, you got to watch the patients, this, that, and the other, but it's, people are going to know that my patients aren't doing as well. So this relates to an issue that's so important in medicine, and that's the fidelity of care. Stephen Wolf is a family practitioner, and here I must give credit to my daughter, Jennifer Griggs, who's a much better investigator than me. Multiple grants, University of Michigan, and she said, you got to learn about Fidelity, because she's learned from him, worked with him. She's a breast oncologist, and she writes all the guidelines for for ASCO. She's head of the guideline industry there. She's sort of the Gronseth for breast oncology. And Fidelity is the extent to which the healthcare system gives patients the right care, essentially. And he's looked at efficacy versus fidelity, and this is something which is the break-even point of new developments. Pharma is only interested in new things that they can patent and sell. And you can understand that. That's forgivable. But we've got to play their game. That's why I said yesterday when I talked about your research, make sure you patent your work before you publish it. If we'd have patented prednisone, we could have done something similar to what's been done with ACTH in infantile spasms, with colchicine in FMF, familial Mediterranean fever, and with tetrabenazine in Huntington's disease. Cheap drug available from overseas, orphan drug protection, now on patent in this country. Patients have to pay for it, and they talk about marketing things. If you have orphan drug protection, that companies, it's a way to make money, and they've learned that. That was the point of the article I showed you yesterday. So at what point does a new treatment have a fiscal benefit to society over the old, just making sure they do the old standard treatment? And this questions, okay, oh, I'm sorry, that's out of order there. So this is the efficacy versus fidelity example is like new versus old statins. Everybody, you could just get them to take any statin. It'd be better for cholesterol than worrying about the new statins. I'm not going to get into the statin myopathy business. But some of the new things versus aspirin, all these oral agents, there's still anywhere around 50% of people aren't taking a anticoagulation for atrial fibrillation, and across the world it's probably 90%. We have not done a good job at T5, global correction of getting the treatments out there and around the world. So this might be true. This is certainly true in cystic fibrosis. There has not yet been any genetic breakthrough in cystic fibrosis, and yet the average survival has gone from like 10 years to 30 years. And there are lots of physicians now with practicing with cystic fibrosis, unheard of 25 years ago. And this has nothing to do with the fact we know the molecular defect. It's everything to do with the fact that we know how to treat them, a little bit to know what to do with the genetic defect, because now we're doing newborn screening for cystic fibrosis in most places, and this means they get started on the supportive care, which is so important to them, and so it's actually improved their outcome. So genetic screening has helped, but it's not gene therapy. And so the same thing probably true in Duchenne. We're talking about antisense. All the patients are eager, worrying about antisense oligos or some new treatment. If they would just get their Duchenne dystrophy taken care of with the right management of the complications of the disease, management of steroids, and careful use of steroids, the outcomes would be so much better than worrying about these new treatments. At some point in the future, the new treatments are going to probably have value added, but not yet. Same may be true for myotonic dystrophy. We can keep myotonic dystrophy patients alive forever with appropriate management, and yet we're worrying. We now know the cause. Charles Thornton knows the cause, has a mouse can fix, moving on to treatment. FSH, we think we are close to a treatment there, but if we just did all the things, those patients don't die of their disease, rarely at least, but they do get disabled, have complications and other things that are all essentially preventable if you do manage them appropriately. So I just want to go back to this question, because I do get asked, why aren't we studying like newborn treatment with steroids? We're interested in that. We're working on setting up a newborn screening program in New York, several other states, working with the MDA. Actually, this is a really exciting project, working in China, trying to set up newborn screening there. Probably not just for Duchenne, but for other things. In terms of an entire province is working with us on doing it. The goal being, at this point for Duchenne, improving the care because of early recognition and doing a randomized controlled trial of steroids in babies. We think it probably is going to be of benefit, but we're not sure. But there are also other regimens, which I don't have time to talk about, that need to be studied after we do this first big study. So how are we going to improve? I say we're looking at these criteria that I already mentioned. These 5 criteria, I think, will improve care in Duchenne dystrophy. And it's my hypothesis that the reporting of such outcomes may improve the fidelity of care and get people to looking at what's the best way to take care of them. Actually, I think it's appealing to neurologists, because I think, in fact, although you won't like to have the fact that your clinic isn't doing as well reported, it'll make you quickly put you in the driver's seat to try to figure out how to improve the care so your clinic does as well as the best clinic in the country. So this is my acknowledgement. You will see this guy in the middle. He's easier to recognize when he has his hat and his cigar, but he can be identified even when he's not wearing the hat. There he is. He's a key figure in this group, and this group is at Beaver Hollow. Yesterday I showed those at Oxford. Next year we'll be back at Beaver Hollow. The way to get there for the young people is if you send an abstract, not only do you get accepted for the meeting, very limited number of people can get there because it's a small retreat-like setting. But if you send your paper in, not only do you get to come to the meeting, if we can raise enough money, which we have every year from NIH and other grants, we can get young people, we pay your way. And so it's a great opportunity to be there, and it's a wonderful planning thing. And you can see some of the other people. I should single out Mike Hanna, one of the key figures, Valeria Sansoni, our Italian, and on around. We have there are lots of wonderful leaders. So try to get to the MSG next year, Beaver Hollow, near Buffalo, New York. I think that's it. So thank you very much.
Thanks, Bert. That was terrific. So, but in your 5 points that you're going to ask all of us to collect in MDA clinics, you didn't have, are they on steroids, or were they ever put on steroids?
Yeah,
Why
we
not?
will put that in there. That's a good point.
Yeah, I think.
On the other hand, you don't have to, because one of the point would be that you look at the data and people say, well, their patients aren't. So yes, you could ask them steroids or other things, and what regimen you might like to know.
Right. I think that's a great idea, though. So, and you didn't, before I ask if there's any other questions, you had the slide on there, you alluded to how long should they be on steroids, but I know you were rushed for time, so you didn't get to it. But how long do you keep your boys on prednisone? 15, 16, 17-year-olds in wheelchairs? What do you do?
Forever.
Forever.
Yep. And I think, I've used steroids. There's enough internists. I've used steroids my entire career, and I think you can keep people on this dose of steroids with appropriate management. They get cataracts, you take them out. I think the bone complications are preventable with appropriate management, and I don't believe there is such a thing as steroid myopathy. Yeah, so I think most of the complications can be treated.
What I think I've been doing is, as the boys are in the wheelchair and they become men, and so their body size doubles, I've been keeping them on the same dose they were on when they were 10, just because less side effects. No one's looked at this, and so
this is the Barron regimen
versus the Griggs regimen.
regimen.
And so I have not increased it, but we keep wondering, should we? Our orthopedic surgeons, you wouldn't think they would be very medically oriented, but they who do our spine surgeries for us, they come back from the orthopedic meetings. There apparently has been some data presented at the orthopedic spine surgery meetings where the boys on steroids do better. Mm-hmm. And so our orthopedic surgeons has been leaning on us, don't take them off steroids, keep them on high-dose steroids, when they're in the wheelchair. They think it helps the scoliosis.
So we've had patients on steroids for 30 years.
Yeah.
Working, married.
So maybe I need to be doing the Griggs approach. Any questions? And Dr. Gertz, here, let me give you the mic. And I know we have some other Duchenne experts in the audience. Dr. White, if you want to ask anything.
Early in my career, the deaths for Duchenne's muscular dystrophy were almost equally apportioned to respiratory failure and cardiac failure, at least in the pediatric literature that I looked at. What's the interplay between steroids and the cardiomyopathy, and then in terms of the study, looking at the kinds of approaches taken by pediatric cardiologists to try to lessen the progression of the dilated cardiomyopathy that occurs. Is there any interplay? Is that going to be part of the study? How are controlling for that aspect of treatment?
So we're standardizing the treatment of cardiac. We're doing echoes regularly, looking for things. We're introducing ACE inhibitors relatively early, using beta blocker, but use standardizing. But I don't have an answer to your question. The one thing I do know is that for any muscular dystrophy, pediatric or adult, when patients develop respiratory failure, the presentation is often with cor pulmonale, and that, unless people are aware of the problem with cor pulmonale, that complicating factor is misinterpreted as a cardiomyopathy, and I've actually seen patients scheduled for cardiac transplantation when they were simply cor pulmonale, and putting them on ventilator, cardiac failure went away. I think that it's tricky, and so I don't have an answer to your question. My hunch is that steroids do help the cardiomyopathy because other people have told me they think it does. And there have been a few anecdotal things for patients with cardiac problems who weren't on steroids or put on steroids, and they seem to be helpful.
I wish you would have looked at that in those old CIDD studies, but I don't think you expected to see such a dramatic effect in the skeletal muscle, but it would have been nice to have, because no one's going to do placebo control anymore.
We should have done a long-term study, no question about it. That would have been really, really good. But this point the other point I need to make about pulmonary function is because I find some pulmonary people especially not everybody knows about air stacking and glossopharyngeal breathing, and so sometimes when you check for the vital capacity of a patient with Duchenne dystrophy, the unsophisticated person may get a vital capacity of 2.5 liters when it's actually 100 milliliters. So because of air stacking, the glossopharyngeal breathing, kids learn how to use their tongue to force air into their lung, and unless you watch them while you're doing it and do the testing correctly, an end-stage Duchenne will increase their vital capacity just by that's what they do.
So in the Griggs method of managing Duchenne dystrophy, what percentage of your patients in the wheelchair are on BiPAP? We have incredibly few, and they don't seem to require it. And we check, and I'm always amazed how few Duchenne young men require BiPAP, but maybe...
Eventually they do. Eventually they do. Now the question, it is an interesting question whether you should use non-invasive. Phil Bach just thinks that it's crime and a shame to use a tracheostomy. But if you don't do a tracheostomy, you're going to lose patients. That's what happens because they get secretions and you can't get rid of them. So the tracheostomy is life-saving. And I have a series of slides I show on that. We had one patient where the 6-year-old sister of a boy on a ventilator could change the trach and look after this. It's not a big deal. It's easy to use, and people talk. It handles secretion. So I think that you need to be prepared to do a tracheostomy eventually because you're going to lose all patients that are on non-invasive. Eventually you lose if you don't do it.
Dr. White does preclinical work in DMD.
Hi. First of all, excellent talk. Thank you so much. I have a question about the Sarepta study done by Jerry Mendel. And I'm not a clinician, so this is probably going to show my ignorance, but Jerry had a paper in New England Journal of Medicine about the immunogenicity of dystrophin proteins in DMD patients. So in the Sarepta study, were those patients immunosuppressed?
Steroids. That was it.
Okay.
I don't think anything else.
Okay.
Yes, but he did. It was a brilliant observation.
Yes.
That there were actually sensitized cells before they started the treatment. This was incredible. That was a big surprise, and this is lessons for not just muscle disease. It's lessons for the entire genetic transplant community, that there is an immunologic reaction. It may have something to do, may influence survival of the engrafted gene, if you will. And so I know they were on steroids for sure. And I don't believe, I'm certain they weren't on anything else, actually.
Thank you. 30 seconds, can you tell them what you're doing in retinal dystrophin?
So our laboratory at Children's Mercy Hospital, I'm now at the Osteopathic College of Medicine here, KCMB, we identified human retinal dystrophin, and what we've been doing is we've expressed it in mice, and we've actually rescued the DMD in those mice, and now we're looking to identify the promoter to see if we could find a pharmaceutical intervention to have retinal dystrophin expressed in the third of patients that have the genetic machinery to make retinal dystrophin in the muscle. They just don't because it's not retina, but that's something that we're pursuing.
Yeah.
Someone needs to pick up on this. And
that's very interesting. Published?
Yes, my work is published.
Yeah, so send me a link to it.
Email it to him.
Yeah.
Certainly.
I'll give you a card.
I'm a pediatric oncologist, and we have a 22-year-old with Duchenne muscular dystrophy who has rhabdomyosarcoma. And he is actually on pulse doses of steroids, like he gets 200 milligram every Saturday and 150 milligram every Sunday, kind of the dose, in a 22-year-old adult size male. So what is the role of, I know I saw that you presented data about alternate day and different doses of steroids, like daily doses. What's the role of pulse doses only on the weekends? And has it been shown to have any different efficacy as compared to daily dosing?
Good, very good question. And I actually showed it on one slide that's one of the unanswered questions. When we looked across all the 100-plus centers, only 4 centers were using that regimen. So that's why we picked the 3 regimens we used. All of them were being used in 20 or more centers. Those are the regimens in common use. Near you in St. Louis, the group have studied, Ann Connolly has studied this regimen, and they reported it in Neurology 2 years ago, that it was equivalent in efficacy and had fewer side effects. The problem is anyone who knows any statistics could see that this was a very small trial, and you cannot establish equivalency, or they actually didn't say equivalency, they said non-inferiority. You cannot establish non-inferiority with the number of patients that they studied. So when you say non-inferiority, and I talked a little bit about this question with fellows and researchers yesterday, it's how much inferiority did you set the bar at when you looked at it? If you set the bar low, like the degree of improvement, the degree of non-inferiority that they accepted was less than the improvement you see with steroids. It was too wide a range of non-inferiority they were willing to accept. So that's how you design your study. Anyone who's used to say something produces an equal benefit requires 1,000 or more cases. To say non-inferiority, it requires fewer, but it still requires hundreds of patients. If you set a really how much inferior, you say we want it to be really pretty much the same. If you look, you see they're not really the same.
So that's the real smart guy answer, which is correct. In practical terms, based on the data we have now, I don't think we know that that regimen is any better or worse. I think it's fine, probably, but we need data, at least from your trial, that these 3 different arms, which won't include that one, but it'll have a different type of pulse. I know here in town, I tend to use daily 0.75 mg per kg based on their paper. My colleagues at Children's Mercy tend to use the weekend pulses. I don't see any difference in the boys that we see, but we need more data.
We need data, and we need to standardize care. Once you standardize care, then you can develop it. You can do a new study.
Right.
But not until
We're out of time, but Dr. Griggs, a little memento of our esteem for your 2.5-day visit to KU. It's a KU tie for anyone who understands it out there.
Oh, and I've got one of these Jayhawks. That's really important.
Jayhawk time again. Thank you so much for coming.
So my pleasure. It was great fun, really, and congratulations again, Dr. Barron.
Thank you all for coming.